Welcome to this Leapfrog Partners webinar sponsored by HealthTrackRx. When it comes to infectious disease, there is a virtual haunted house of diagnostic errors, access to treatment challenges, and rapidly spreading resistance that all can be frightening. What we'll cover today is the real-world impact of next morning molecular testing and the impact on clinical workflows and patient outcomes. We'll also discuss how diagnostic speed supports antibiotic stewardship and lowers cost of care. And we'll talk about some of the gaps in current reimbursement structures and implications for quality and access. And most importantly, we'll talk about what forward-thinking employers, payers, and health systems can do to lead in this time. I'm Ben Favre. Today, I'll be your moderator. We've assembled an expert panel to guide us through these frights and give us a path forward. Joining us first is Leah, CEO of the Leapfrog Group. Leah will be talking on misdiagnosis in a crisis hiding in plain sight. Next, we have Dr. David Nash, the founding dean of the Thomas Jefferson School of Population Health, speaking on rural America is being left behind. Next is Dr. Barbara Alexander, a professor at Duke University and past president of the Infectious Disease Society of America. Stephen Goldberg, a clinician at University of Louisville Health and chief medical officer at HealthTrackRx. As far as disclosures, Dr. Alexander has disclosed her relationship with 3 companies. All of these relationships have been mitigated by peer review and disclosure. All other speakers, reviewers, planners, authors have no financial information to disclose. So let's jump right into it. Give us your perspectives based on all the work Leapfrog has done, misdiagnosis, safety, quality, and the impact of diagnostic errors.
This is an issue that Leapfrog has taken a great deal of time to understand. We were particularly interested when the National Academy of Medicine came out with a report a few years ago suggesting that misdiagnosis was a problem on the scale of patient safety, and we actually consider it within the realm of patient safety as a critical element, and define it the way we define problems in patient safety, which is to say, we don't see it as the problem of one individual, maybe somebody who makes an error in diagnosis. We don't see that as the problem per se. That's just human nature, right? We absolutely know that there will be mistakes made in healthcare and there will be misdiagnoses. We know that for certain. The issue is, how can we prevent an error or a misdiagnosis from impacting the patient in a negative way, from harming a patient? That's the issue. There are real steps that hospitals can take, that physician practices can take, that lots of folks can take. And the problem, as I said, is extreme. We were fairly shocked, frankly, at Leapfrog when we looked at some of the research that's out there. There are 3 major disease categories that account for 75% of the harm from diagnostic error that we know to date. And I should say that is very important because I think the research on diagnostic error is really almost at its infancy. We're still really learning. To date, we believe these 3 disease categories account for most of the harm: vascular events like stroke, infections, and cancer. And that is from David Newman from Johns Hopkins Medicine, who's worked very closely. He's one of our key expert panelists, has worked very closely with Leapfrog as we have explored this very important issue. The National Academy, in that report I just mentioned, put out the statement that most of us will experience at least one diagnostic error in our lifetime. And that actually has, on an anecdotal basis, been absolutely true for me. I will tell you, every single person I've ever talked to about this issue has a story. Every single person, including myself. Leapfrog took this on. We put together an expert panel that included patients and families, as well as employers and purchasers who take a great deal of interest in this. And those are key constituents of the Leapfrog group. As most of you know, watching this webinar, know that you're involved with Leapfrog, and you will know that Leapfrog is really driven by employers and consumers. And it's a very important issue to them. We brought together this expert panel and we distilled the literature that we had and tried to come up with, well, let's come up with a manageable set of recommendations for health systems on what they need to be doing about diagnostic error and in order to have diagnostic excellence, which really is the goal. They distilled 22 recommended practices over a course of over a year of convening and researching, and a framework to guide implementation. which again has been widely distributed, is available for free on Leapfrog's website to anyone who's interested. What we've now done, this is, as most anyone who is involved with Leapfrog knows, this is the culmination of work when we do involve experts in looking at key issues like this, is that we have actually put questions on the Leapfrog Hospital Survey. Those have been pilot tested and vetted, and they continue to be on the survey and will continue to be on it next year. These are not scored and publicly reported yet because, as I said, the research is still somewhat early, and our recommendations through these expert panels have been still at their early stage. But we are very interested in having hospitals look at these questions because they're really key in understanding what we found were the most important interventions that hospitals in particular can do to address diagnostic errors. So number one on that list, CEO commitment to diagnostic excellence. You got to have the top leadership who really believe this is a priority. We've got to solve this issue. Patient engagement is very important, and we have very specific steps in our recommendations on how to make that happen. Assessment and mitigation of the risk, and then having a team, multidisciplinary team, involved in diagnostic excellence within an institution. Multidisciplinary is an important word here because, as I said, it's not just about the one clinician who may be making an error in diagnosis. It's not about that. It's really about how all of the teams come together and recognize if there's an issue or a problem or an opportunity in diagnosis and come together to solve it as rapidly as possible before it harms the patient if there's a problem. Training and education and closing the loop on cancer diagnosis. One of the issues with diagnostic error is that sometimes it's really not very complicated things that are incredibly difficult and even catastrophic for patients, such as somebody forgot to deliver the lab result to the physician. I mean, simple as that. And that is very common, and it's a diagnostic problem. So it is closing loops everywhere throughout an organization. So these things are very important to us. They're very specific questions. We hope that hospitals are able to embrace these and begin to take the steps necessary. What we have found in our research working with hospitals is that they're really at very, very early stages, that not too many hospitals have really fully embraced this challenge. And we hope that they will take this on because there's lots of opportunity to make a very significant difference in the lives of their patients.
You mentioned, everyone will be touched by this. And before you were the CEO of Leapfrog, you were a mom, and maybe that's the most important job, maybe more important than Leapfrog. How has it impacted you personally, from a patient perspective, the importance of getting a rapid, accurate diagnosis?
Well, yes, I am a mom, and you're right, that is the most important job in my life. But when my children were little, I'm certain that there's moms and dads, any mom and dad watching this, I'm certain you know this experience. You go to the pediatrician, your 2-year-old is coughing or has a fever, something is just not working right, and you say, can I get a prescription? You just want something because your baby's up all night. It's driving you crazy, the family crazy, and obviously the most important thing is it's your child is suffering. You want something. And for pediatricians, it's so hard because they might think, well, it's not really an antibiotic that would do something. Maybe it's viral. I don't want antibiotics overuse. There's always this tension. Of course, I wouldn't do this, but there's lots of parents. They'll look up on Google, what are the symptoms that will get me an antibiotic prescription? And they'll say that's what the symptoms are. People will do that. They will do things like that because they're so desperate to have an answer. They'll be testing and it takes days. Days is a long time when you're a parent and you're trying to navigate a very complicated family life and work and everything. It's incredibly frustrating. We have got to be able to use technology in better ways to make that an easier journey for the parents and the babies.
So Leah, want to cover your key messages and call to action real quick?
Well, we need to invest in the tools so that we get these things right the first time so that I can get a diagnosis when I bring my kid in with my 2-year-old, but also just that policy is making it worthwhile for hospitals to take on this issue, embrace it, and make a big difference. We just clearly have not created that environment. We have not created the incentives necessary to make misdiagnosis and misdiagnosis a huge priority in hospitals where it needs to be a priority. As I said, it is a very key component of what is harming patients throughout this country. So it's not a trivial issue, it's a major issue. It should be a top priority. We're going to need policy to support that, and we're going to need financial incentives as well.
Excellent. Thank you so much, Leah. David, Leah talked about diagnostic errors are a major issue, and specifically the three types, infections being one. From a population health perspective, talk to us about the importance of access and availability to diagnostic options and the issues that impact populations in total.
Sure. So first of all, really great to be here. And I want to take a moment to thank Leapfrog Group and of course, Leah and her whole team for co-sponsoring this, and Steve and the team from HealthTrack's. And I can't help but think that Leapfrog has been in the front of so many of these issues. And you could summarize so much of that work as healthcare is never going to be error-free. What we all have to work hard to do is make it harm-free. And that's true in the office, in the emergency department, and certainly in the urgent care center as well. So we're never going to make it error-free because it's all about people, but we've got to make it harm-free, including misdiagnoses. So what a great take-home message. Well, Ben, you know, I'm all about the triple aim and maybe the quadruple aim. So let me frame the answer to your question and put it in the context of the triple aim. And this is a sophisticated audience, but I needed reminding that Don Berwick first talked about the triple aim. Are you ready? In 2007. So that's 18 years we've been thinking about these three components. So let's do a quick review, and then we'll drill down to what we're talking about today. So when it was first articulated, the triple aim was all about improving the health of the population, which seemed like a pretty far-reaching aspect of this, given that it was in 2007. We're still struggling with appropriate measures as to how do you actually catalog improving health for a large population. We'll come back to that in a moment. The second piece was reducing cost. But here's the key connection. Reducing cost really means reducing waste. How do we reduce waste? We have the right diagnosis with the right therapy at the right time for the right patient. So you can't fix the cost crisis by focusing on cost. That's the zen of the triple aim. You have to focus on the waste. That's where really all the cost really is. And this audience knows that high quality care ultimately costs less for lots of good reasons. The third component of the triple aim, as exemplified on the slide, is improving the patient experience. Well, I'm not going to ask for a show of hands as, you know, who has ever had a sort of, you know, not great, untoward patient experience. Every single person, every doctor, every nurse, every pharmacist, every employer knows exactly what we're talking about because the system is not designed with the patient at the center. The quadruple aim, relevant of course, but not key for today, adds the notion of provider well-being, doctors, nurses, pharmacists, and the whole idea of the second victim, a big topic, really important, but not for today. So summary, the triple aim has, you know, three goals: improving the health of the population, reducing waste and thereby reducing cost, and improving the individual experience of care in multiple levels and in all settings. I think expanding access to the tools that HealthTrack has created really is sort of a key aspect of moving the triple aim forward. It's going to improve the health of persons presenting with respiratory illnesses to be able to do accurate, evidence-based, overnight diagnoses. It's certainly going to improve the patient experience because you'll be able to get the right information at the right time. And it's really going to reduce costs by reducing antibiotic wastage. And Barbara's going to cover all the important issues on stewardship of antibiotics and so on. You know, I've been so grateful to be a participant on the advisory board for HealthTrack. I'm all about getting the right information to patients at the right time with good data that is evidence-based to support the appropriate diagnosis and the appropriate therapy. I mean, to some extent, if you take a step back, the new technology we're going to hear about really hits all aspects of the triple aim. And as the slide alludes to, I think definitely reduces complications and misdiagnoses, certainly. Definitely gives patients the peace of mind, especially parents, helps employers and Leapfrog members by getting people back to work, and ultimately could definitely reduce hospitalizations, reduce unnecessary return visits, and certainly reduces unnecessary testing. We are setting a new standard of care that closely adheres to the tenets first described 18 years ago in the triple aim. For me, as a population health guy, at least in this context here today, I mean, this is a winning technology for everybody. And that's why I'm so excited to play a small role in helping folks to understand what this is all about. So, I'm not a rural care expert, but from a population health perspective, boy, that's a population that really is in trouble from a healthcare perspective, right? So we're closing rural hospitals left and right. There aren't enough primary care doctors in the city, let alone in rural America. They don't have access like we would want them to have. And I think in the whole access conversation, what I've been learning about and teaching about is, look, you can't achieve value without equity. I mean, that's really, I'm sure most folks get that. But how can we be talking about value-based care when we're really not in any way in an equitable system? In fact, you could argue that the current system is an engine of inequality. And rural healthcare, double what I just said. So as the key messages say, in a medical specialty desert, I mean, the delay in diagnostics, the delay in therapy is going to add to waste and is going to be a poor patient experience and certainly is not going to improve health. Next morning testing, when done right, it's not a luxury. It's really a lifeline in complex cases, and certainly really important in areas that we would label as communities that need these services. So to summarize, wow, you don't find too many technologies that move the ball down the field, if you would, and that are a cornerstone of a concept that Triple Aim first articulated, in 2007. So today, as I'm playing one small role here with these great faculty as part of the call to action, and I would just close with, you can't have value without equity. That's the take home.
It's a great message, David. Thank you. And I love your perspective, thinking big picture like that. Dr. Alexander, Leah and David's comments both create tremendous urgency around this problem. What are you seeing at the bedside? And give us your clinical perspective and the data that's out there related to rapid testing.
Well, I think at the bedside, what I am definitely seeing is some clinical urgency around this issue. We're seeing the number, actually, I would go one step further, Ben, and I would say what I'm seeing is the perfect storm is brewing here. So we have an increased number of patients that are at risk for infection that's growing, and the care of these often medically complex patients is shifting into the outpatient setting, which is leading to more empiric antibiotic use, and that ends up contributing to rising rates of antibiotic resistance, which we all recognize as a growing public health emergency, not only just in this country, but globally. So what I'm seeing at the bedside is some urgency in terms of trying to bring new technologies to the table. Stepping back a little bit and thinking about when I said that the population of immunosuppressed patients is growing, well, who am I talking about? Where are these patients coming from, right? Well, first and foremost, I would point you to our aging population here in the country. On the graph on the right, you see that the number of Americans that are over the age of 65 has actually tripled over the past 40 years, and it's expected to increase by another 25%, reaching 80 million by 2040. And what we know about aging is that it's associated with immunosenescence. And for a lack of better description, immunosenescence is just a natural wearing out of our immune system. And so with aging and immunosenescence, what we have are older patients who are more vulnerable to bread and butter infections like pneumonia and urinary tract infections. They also can develop other age-related medical conditions that further weaken their immune system. But also backing up and looking at that green box, it's not just this growing older population that we have here. Younger people who have weakened medical immune systems from a variety of conditions also contribute to this population. So for instance, patients with cancer obviously need chemotherapy. People who need solid organ transplants go on to need medicines that prevent rejection. Even some of the immunologic drugs that have come to market, you hear these advertised routinely on TV, drugs for rheumatoid arthritis or ulcerative colitis or even psoriasis. Some of these immunobiologic drugs, right? They work by altering the immune system, and so their side effect is increased risk for infection. So we're seeing a number of not only older but younger people with a variety of weakened immune systems from different types of therapy that they are receiving. I'd also highlight from here that it's not just a growing population. We're taking these patients now and we really are moving their care into the outpatient system. I have listed here on this slide hematopoietic stem cell transplant. We've called that bone marrow transplant historically. Well, we historically would only perform a bone marrow transplant in the most hygienic areas, these sterile environments in a hospital, HEPA filtered environments. We have now started performing these bone marrow transplants in the outpatient clinic, right? And so these are really, really vulnerable patients that if they get an infection, then the stakes are really high that the infection could become very severe. So ultimately, I think the bottom line here is that we are seeing more immunosuppressed patients and really vulnerable patients at risk for severe infections, so that as a provider, if I'm in the clinic trying to take care of these patients, if they've developed a first sign of an infection, a sniffle, maybe a little low-grade fever, the first thing I'm going to do is add an antibiotic because I'm giving them a safety net, right? I want to make sure that I intervene and that they don't develop severe disease, severe infection. But unfortunately, I did that blindly. I don't know that the patient actually has an infection, and I certainly don't know that their infection will actually respond to the antibiotic that I administered. And so this blind prescribing of antibiotics, even though we're doing it for the right reasons to try and help the patient and protect the patient, what we find is that empiric antibiotic prescribing is getting us in trouble.
Empiric antibiotic prescribing, how do we break that cycle? And what are your thoughts on the data around diagnostics in their use?
You know, the cycle is demonstrated here, and if you look at the upper right-hand corner, what I would point you to is that empiric prescribing is causing the use of unnecessary prescriptions. Actually, from the CDC is shown here, it's estimated that at least 28% of the antibiotic prescriptions that are written are unnecessary. And we know those unnecessary antibiotics can have unintended consequences, right? So they can have side effects like diarrhea or rash. And actually, if we look at this next statistic, 20% of the medication-related emergency room visits are from antibiotic side effects. That is one unintended consequence of these unnecessary antibiotics. But another unintended consequence is the development, then the overuse is leading to the development of some of these bacteria becoming resistant. And then when a patient develops infection with these resistant bacteria, that they often require hospitalization for inpatient IV antibiotics. And often these infections will actually no longer respond to the antibiotics that we have available, and some patients will die. So when I think about breaking the cycle of empiric prescribing, the tool that I need first and foremost is a better diagnostic that's going to allow me to more accurately diagnose the infection and to diagnose it more quickly, so that I'm making sure that only the patients that need the antibiotic receive the antibiotic, and that those that do need the antibiotic receive the right antibiotic. So trying to avoid some of those medication errors that Leah was mentioning.
Is there evidence out there that providers will actually change their prescribing habits if they had access to better testing?
What I'm seeing on the front lines is that providers are anxiously awaiting the availability of these new technologies and tests that can help them provide better. And I think they are willing to change their prescribing patterns if they are reassured that they have a new test that's going to actually help them make the best decisions for their patients. You know, we do have these multiplex panels, these PCR panels that now are syndrome based, so that one-stop shopping, right? You have a single test that has the most common causes of a bacterial pneumonia on there. We even have some resistance markers that help guide the physician or the provider to make sure that they're staying away from drugs that might not work. These types of tests are really allowing the provider to really individualize the care of the patient based on the patient's risk, their unique risk for, having bad outcomes versus the actual organism that's causing the infection. Again, I do think that the providers will be willing to embrace this technology. Actually, we just recently published a survey from over 600 providers where they had access to this next day syndromic PCR testing. 83% of them said they found that they had improved prescribing accuracy and or fewer antibiotics by using the test. And perhaps even more importantly is that 98% of them reported that the next day results helped to improve their patient outcomes, and things that they specifically listed included fewer unnecessary antibiotics, fewer return visits, and faster symptom resolution. We actually need to confirm this type of data, but I do have optimism that people will embrace the testing if it's available for them.
So there's data out there, there's clearly an urgent problem. Dr. Alexander, what are the forward-thinking leaders in this space thinking? And you're president of the Infectious Disease Society of America. Where is this going, and how do we kind of get action taken more rapidly?
Forward thinking, and I guess really innovative leaders are really trying to think about these technologies in terms of how they can make care safer in the outpatient setting. How can we really improve the care of these patients and make it safer? And I think the really, really innovative leaders are thinking multiple dominoes down the road, and then can we also use these same tools to help address this issue that is rising antibiotic resistance, which also has incredible consequences, right, in the long term. I think the issue becomes that there are multiple stakeholders at the player, right? So if you look here at all the different stakeholders that we have listed, each stakeholder is looking at these new tests and new technologies through a slightly different lens. For instance, the payers and the healthcare systems want to make sure that the upfront cost of the testing is actually worth the investment in the long run for them, whereas the patients and the providers really need reassurance that these tests work and that they're helping avoid the medical errors. And then you have the test developers who just really need guidance. There's a lot of different outcomes that could be measured, but what is their test performance going to be judged against? What is the endpoint? A clinical trial to assess performance of a test costs millions of dollars. And so you can't just go into these multi-center clinical trials willy-nilly. You really have to carefully think about what the endpoints are that we want to prove, how we want to prove performance. But if you go around the table and ask 5 payers what they think the most important outcomes are, you might get 5 different answers, right? I've just taken the liberty, I guess, of including some potential outcomes that we could think about measuring in this green box over here. For instance, if we wanted to look at healthcare resource utilization, does the test reduce the number of return visits, or does the use of the test reduce the number of hospitalizations? We're looking at improved safety. Are there fewer adverse events from an antibiotic with using the test, or perhaps are we able to get patients back to work or back to activities of daily living sooner? And then if you really want to look at, from a public health perspective, okay, well, are we impacting antibiotic pressure? So are we actually writing fewer unnecessary prescriptions or perhaps fewer total antibiotic days? I think what we really, really need from innovative leaders, from all of these stakeholders, is to step up and really take the lead in driving consensus on what we think are the most important outcomes to focus on, so that then we can get busy getting the necessary data gathered, so that then we can get these tests into the hands of the clinicians. Technology has not only improved the care of patients, it's just changed fundamentally not only how we care for patients, but where we care for patients, right? We're taking care of patients increasingly in the outpatient setting. And in that setting, next morning test results do become critically important, especially for these very vulnerable patients who are at risk for poor outcomes from infection. And then lastly, as the infectious disease physician and antibiotic steward in me, I can't help but point out that hopefully we could use these tests to also impact that cycle of antibiotic resistance. At least on some small level, we could do our part in helping to address that.
Fantastic. Thank you, Dr. Alexander. Dr. Goldberg, Dr. Alexander mentioned resistance. Dr. Nash mentioned resistance. Leah mentioned resistance. I mentioned it in the opening. It's one of the scary things out there. Through the lens of an urgent care provider, what insights do you have and what clinical review data do you have that you could share with us?
In addition to seeing patients on a regular basis, I do a clinical review for HealthTrack. So I talk with clinicians when they order our tests and we have a report to share. And I didn't expect this before doing that work, but in the past 60 days, I've had a couple cases where a patient presented, they had clear illness symptoms. The report showed they had a clear pathogen, but on the pathogens identified, there were so many findings of resistance to antibiotics. There wasn't a clear option for outpatient antibiotic treatment in 2025. And that's very scary. Dr. Alexander, who advises us, was available to me to consult on those two cases. And I called her and said, "Is this how I'm reading it?" And she said, "Yes, you are." And so we figured out counsel to give to the clinician about re-referral of the patient. I never thought we'd be confronting that, but resistance is here and we're dealing with it right now in 2025.
What other data is out there? Those are kind of the extreme cases, but just regular respiratory illness cases.
Let's kind of start with what we heard. Leah Binder really reminded us that this conversation is about getting the diagnosis right, and getting the diagnosis right is a critical part of safety. And patients today have the expectation that they want a specific diagnosis. Dr. Nash reminded us about the triple aim construct, thinking about care, health, and cost, and the importance of equity. People should be able to get excellence of care regardless of geography or income. And that has to be a charge for our new technology. And Dr. Alexander, who's taking care of very vulnerable patients, immunocompromised patients. And with technology, we're moving their care to the outpatient setting, but they confront infection. And when they have infection, you really need to get that diagnosis right so they work and they can live and not have a problem if you get it wrong. So all these are important conditions and considerations as we think about resistance. I just want to step back and remind people about resistance. Resistance will be the leading cause of death in the world in 2050. That is astounding. In the United States, complications from resistance and resistant infections cost the system about 21 to 34 billion annually, lead to 35,000 deaths annually, and annually more than 2.8 million antimicrobial resistant infections. I described two cases of them. They're 2.8 million a year. Now, when we think about ambulatory care providers, and that's where I spend a lot of my time clinically and professionally, we're dealing a lot with bronchitis. It's a very common complaint. Respiratory complaints are most of what we see. Bronchitis is a common problem. It affects 5% of all adults in the US. And the scary thing about how we're not using precise diagnosis and how we're overutilizing antibiotics is that it's estimated by the CDC that up to 50% of antibiotics for acute respiratory tract infections are inappropriate. That is enormous, and that is escalating the cycle of using antibiotics when they're not necessary, which is a critical contribution to the development of resistance.
What about the issue of patient communication? And Leah had talked about that tension between a patient and a clinician sometimes. What are your thoughts on that? Because it is a resistance issue ultimately.
It is a resistance issue, but that's a very nuanced topic. And when someone's coming into the clinic not feeling well, or the child's not feeling well, and they have pressures at work or childcare or even income, it's an expense to come to the clinic. They need a way to understand the problem that's digestible for them. So the CDC and others have tools about talking through what antibiotic resistance is. There's an illustration here about be antibiotic aware. But the key messages with that involve educating people about the difference between viruses and bacterial infections. Not too deep, but enough for folks to understand that if clinically we think you have a virus and we can confirm you have a virus, antibiotics won't be helpful. And if anything, they can be harmful. So it's explaining the why not when withholding antibiotics for patients when a bacterial pathogen is really not likely. And taking the time to go through that is a shared decision-making process. And so if you take the time to educate them, they can be satisfied. And we've published on this very topic recently. And this is an illustration of a report that one can use in a shared decision-making conversation. In this report, circled in red, it identifies that the patient has an adenovirus. Well, one can take this report immediately from the clinic or in follow-up in a phone call and have a conversation with the patient to explain why antibiotics are not indicated and have a shared decision-making conversation about the risk and benefits and concerns about antibiotic misuse. And the studies that Dr. Alexander led, where providers were surveyed, show that when they have access to this type of information and engage it, they're more careful with their use of antibiotics.
Great review. You made resistance a lot less scary, but I have to tell you that 2050 number is downright scary when you think of it in that context. Dr. Goldberg, any key messages, call to action that you want to cover for us real quick?
I'll begin by saying whether it's an immunocompromised patient or it's a patient with chronic disease or someone without chronic disease, the expectation is in 2025 to get the diagnosis right. And as clinicians, we need an easy button to enable clinicians to talk people around a right treatment for the right finding. It's our view, and we believe the literature is showing, that judicious use of molecular testing can be a good tool for clinicians to get the diagnosis right and the treatment right. And it also appears in the literature that prompt results, by prompt results, we mean next day, give them the best opportunity to engage the patient and use best, thoughtful, judicious use of antibiotics.
Excellent. Thank you, Dr. Goldberg. AI seems to be anywhere and everywhere that you look these days. When it comes to issues of antibiotic resistance and getting patients on the right antibiotics at the right time, what can be or do you think should be done in the world of AI that may help us? And I'll open it up to anyone on the panel that wants to take a stab at that, or anything you see coming down the pike that would be of interest.
Well, as an ID physician on the wards, we have some very complex resistance patterns that emerge, and they can be very complicated to interpret. So if you have one resistance pattern, which antibiotics can you or shouldn't you use? And then you have to include intolerances perhaps of the patient, so individualize the choice. An application for AI would be really we have new and emerging mechanisms of resistance. And as these mechanisms re-emerge and we are able to test for them, really having a sophisticated system that can analyze then, bring to, in a nutshell, then which drugs are yes and which drugs are no. And I guess you could potentially have a maybe category, but only if absolutely necessary. So
physician support tool.
Yes,
Yeah.
especially as it relates to a lot of the new mechanisms of resistance and testing for them molecularly.
Anybody else?
I've downloaded Open Evidence and other tools, especially the new up-to-date that's got AI attached to it. So, after doing 18 years of inpatient teaching, attending in a general medicine, you don't need me anymore. You got Open Evidence, and you have up-to-date, you have AI. I mean, it's amazing. And when you drill deep into some of these tools, they have already absorbed the resistance data. Not for super complex patients that Barbara sees, but certainly would cover what you'd see in the office, what you see in urgent care. So these clinical decision support tools, aided by AI, I think this is a entirely new waterfront of important tools that can help us.
Leah, Dr. Alexander talked about changing physician behavior and how difficult that is. Leapfrog has actually been pretty successful in changing physician behavior and getting them to adopt new programs and stuff. What do you see as far as relative to this type of testing you envision being done? And is there a role for AI within Leapfrog as well?
Physicians have not only been responsive to what Leapfrog has been discussing with regard to patient safety, but they themselves have been informing us. I mean, we've learned from physicians immensely. They have come to us with some of the best insights that we have. They make up our expert panels and everything else. So we are reliant on the expertise from physicians. I would say that the approach that Leapfrog has taken and has had some influence on in the delivery system is that diagnosis is not an individualized phenomenon. It's a team sport. It requires everyone to be involved. It is not one person's responsibility, an obligation, which is a huge burden to put on any one individual, nor is it their fiefdom, frankly. I mean, we have to look at diagnosis as something everybody's got to be involved in. Everybody's got to feel comfortable speaking up. I think having AI as part of that equation is incredibly helpful in moving toward that team sport orientation toward diagnosis, because AI is very good at synthesizing tons and tons of information and perspectives and ideas, bringing them all together in an analytic way, the way the human brain would bring them all together, not just memorizing stuff, but actually bringing it all together and saying, wait, I think blah, blah, blah. It's just a remarkable, very new technology. That is remarkable because it is truly a breakthrough in the way that you think of a digital operation. I think of a digital operation as reciting to you back some memorized list of common causes of something or chemistry or elements. That's not so much what AI does. AI says, well, you need to think about this, and there's another perspective on that. That's the kind of thinking that physicians frequently go through in a diagnostic process. Yeah. By bringing AI into it, you're bringing actually in all these new perspectives and the recognition you need all those perspectives in order to get the very best diagnostic excellence.
Dr. Goldberg, Dr. Alexander, we have a question from the audience here. What do you do when you have multiple bacteria, H. flu, staph, etc., on a PCR result, and because you aren't sure what organisms are the true pathogens, could potentially lead to increased antibiotic use, and say for a patient with bronchitis or something? What advice or guidance would you have in those scenarios?
I think the most important thing is to realize it is a diagnostic insight. And the first thing is to think through the patient's clinical history and presentation. Things such as whether the patient has a fever, do they have an underlying chronic condition, have they received an antibiotic recently, what is the clinical exam, are we thinking about a bronchitis picture versus a pneumonia picture, their age, other considerations. You can get a lot of good approach by considering those factors. You can't just go to the diagnostic insight. Putting the diagnostic insight in that context, things become a lot easier. That's my experience.
There are tricks of the trade when you're thinking about these test results. Hopefully the company has put the most important pathogens, potential pathogens, and taken off organisms that are not typically involved in causing infections or the particular syndrome that play. We can look at the quantitation, so the amount of organism that's there relative to other organisms to decide what might be a dominant pathogen. And then another hopefully helpful thing are comments that the companies can include in their reports. For instance, if you need to have pneumococcus there, but in pediatric patients, we know that it can be a normal part of the flora, then maybe a comment indicating that. But I think ultimately you have to take all of these clues and you have to think, right? These are not just test results respond. You have to think about them, as Dr. Goldberg has said, in the context of the patient and the clinical syndrome that the patient has.
I'd like to thank all of our panel members. Fabulous job. Thank you so much. And with that, we will conclude the webinar, and thank you everyone for joining us this afternoon.